we'll just be sort of brief in this part, but tell us about yourself, Daniel.
Okay. Well, I did medical school at University of Illinois, and then residency at Northside Medical Center in Youngstown, Ohio. And I didn't do a fellowship. I did straight general surgery, and then came to Hoopeston, Illinois, which is where I am currently. So I've been here for about 11 years.
Excellent. All right. Brian, how about you?
Thanks. Excuse me. So I went to graduate medical school in Milwaukee at the Medical College of Wisconsin. I did my residency in general surgery at the Gunderson Health System in La Crosse, Wisconsin. I practiced in Wisconsin for a few years as a rural general surgeon with a practice in vascular, thoracic, a little bit of peds and general surgery. I moved to Rochester, New York, where I've been for the last 16 years. And the path has brought me many different places. I'm currently on the Advisory Council for Rural Surgery and the Rural Surgery Quality Committee with the American College. Got a broad spectrum general surgery practice. I'm no longer a true rural surgeon because there's many things that I did as a rural surgeon that I don't do now. I'm the surgery clerkship director and the director of surgical education in our health system.
Wonderful. All right. Scott.
My name is Scott Smith. I went to medical school at the University of Alabama, Roll Tide. I did my general surgery residency at Baptist Health Systems, which was a community program in Birmingham. I did a year of endocrine surgery fellowship at Rush University and then wound up back at Baptist for about 8 years as part of the teaching faculty. I'm currently in Lewistown, Montana, which is small town in central Montana. I've been here for 6 years and currently the only surgeon in about 120-mile radius.
Okay. And Russ, and then we'll get to Celeste.
Hey, Russ Juno. I graduated University of Texas Medical School in Houston, and then from there went to the University of Cincinnati. I did 5 years there, plus I also did 2 years in the lab at the Cincinnati Children's Hospital. So I finished up in 2006, and since then I've been in LaGrange. Currently I'm chief of surgery and anesthesia here. I've been on the hospital board off and on several times. Also sit on the Advisory Council for Rural Surgery through the American College of Surgeons, and then also been on several committees and boards with the Texas Medical Association.
Wonderful. And you must know ZZ Top too, right?
Yes, got to hear them play. They actually played, I think it was 2015. It was their only time they ever played at our county fair. Got to hear them.
And lastly, my good friend Celeste, who I think I've known for probably 20 years now.
Yeah, it's been a minute, hasn't it? So I'm Celeste Hollins, and I'm a little bit of a hybrid in this section in that I am actually a practicing pediatric surgeon, but I practice in an area of Texas that is a little bit rural and interfaces with a lot of rural surgeons. So I think I bring a little bit of a hybrid flair. I went to medical school at the University of South Alabama, did my residency at the Graduate Hospital of the University of Pennsylvania for general surgery, did a year of pediatric trauma at Children's Hospital of Philadelphia, and then my pediatric surgery at Children's in Miami. I have been an academic surgeon for 20 years. 4 years ago, almost 5 years ago now, I moved to Lubbock, Texas to join Texas Tech for what I thought was going to be a straight academic job. And just because some changing environment, I actually am at the community hospital building a parallel practice there and doing a lot of work in quality and serving our rural areas. So I'm not a true rural surgeon, but I think I can answer some questions and bring some perspectives.
Wonderful. Well, it's always good to see you. as always. Maybe I can go back to Dan if it's okay. Dan, what skill set do you need to be a rural surgeon compared to, say, a general surgeon in a suburban or urban practice? What other skills do you need?
Well, a lot of it depends on where you're at. I don't think I've met any two rural surgery practices that are the same, having met a lot of my colleagues at the college meetings. I think in general, endoscopy is an essential for rural surgeons. And then some of the other invasive procedures, anything that involves a needle, like thoracentesis and paracentesis and biopsies and such, you should have a comfort level with being able to do. Other than that, a lot of it depends on your own training and what the needs are of where you go. And you can always learn to do new stuff too if you have partners, of course.
So Brian, one of the my background was, interestingly, despite being in Nebraska, I was also in the military, and one of the greatest challenges I found was that I myself might have the knowledge and the skills how to handle a situation, but the environment I found myself in wasn't ready, for that type of care, and I had to move them to a higher level of care. How do you navigate that in your practice, and how would you prepare, say, medical students to deal with that contradiction, that you have the ability, but maybe your setting or environment just might not?
That's a great question, and thank you for your service. I myself was a jarhead, so I can appreciate that. In 20 some years of practice, my practice has changed, and it is a challenging situation from previously, where the only decision was how am I going to take care of this patient, as opposed to should I take care of this patient? Having the skill set to be able to do so, but perhaps the facility you're in does not. I think stabilizing the patient and doing what is necessary, and then transferring them to a more appropriate facility is very reasonable. I think we have to keep in mind that this is not about us. This is about the patient. So if you're in a situation in which you don't think you could provide the optimal care because of whatever reason, maybe you don't have an ICU, maybe you don't have round-the-clock coverage of respiratory therapy, whatever it may be, I think you have to think about that. But in life and death situations, you take care of the problem and plan. If it's not a life and death situation, then you make arrangements that best serve the patient.
So Scott, when you're, there's a question from the chat, and that is, when you're in a rural environment, or sometimes the needs within that rural community are different than, say, what happened in an urban or suburban. How do you adapt your own learning and education to meet the needs of an environment that maybe at an academic center you didn't necessarily encounter, but now you see it, say it's delivering a baby by C-section or something that during your training may have been covered by somebody else, but now you have to learn?
That's a great question. And honestly, surgery is kind of a lifelong learning environment. I don't think any surgeon would say that they've ever mastered the art of surgery, and that they reach a point in their career where they stop learning. And I remember one of my attendings telling me about his ability to add laparoscopy to his career, and then add endovascular surgery to his career later in his career. And from a rural surgery standpoint, I find that that's true for me as well. But the thing is that I tend to wind up learning maybe despecialization. So once I moved to Montana, I learned how to do tonsillectomies. I spent time with urologists learning how to take care of a torse testicle. I spent time with OBGYNs teaching me how to deal with ectopic pregnancies or tourist ovaries, a variety of things that may not be high-end subspecialty procedures, but are things that are encountered and may even be either time sensitive or life threatening, that if they're not dealt with immediately may result in a bad outcome. So I've had to kind of adjust the way I think. I'm not necessarily learning new robotic procedures. I'm learning how to despecialize myself and kind of move away from some of these more subspecialty focuses within general surgery to become more of a complete surgeon.
So let me ask Russ a question if I can. So Russ, I actually did my residency in Portland, Maine, and most of my co-residents went into a rural practice. And one of the challenges I think they have had was, being the only guy in town to deal with questions and problems. Russ, how do you deal with that? How do you keep yourself educated and up to date, and also, because it's hard to go to conferences and things like that when you're in a rural place. How do you keep yourself knowledgeable?
Well, I think now in 2021, we've got so much technology, and you just have to take advantage of all that. Like the past two clinical conferences have all been online, and you can do it at your own pace. And I know they are recorded and stuff. And I know even the college has, even in the past, even when it was in person, had CDs and online stuff you could get too. But very early on fortunately, I had some other surgeons here in town, but I learned actually reading through one of the American College of Surgeons magazines, read about a rural surgeon, Dr. Tyler Hughes. One time wrote an article about being a rural surgeon, and lo and behold, I was able to find his email and got a hold of him. And at that time, he and Dr. Phil Carapresso were working on some early technology, what we take for granted now for the rural surgeons to kind of connect us. And so there was an online portal that was available to the surgeons. And so that was kind of like what we call our operators lounge or surgeons lounge, where we could go post questions. And eventually that developed in to what was called the rural listserv. And then eventually now a lot of us here, fellows of the college, know as the communities. So you do have to ask questions, and there is no stupid question except the question you don't ask. So again, technology now I think is a lot easier. Videos, and to be honest, YouTube and so forth. You sit there as a rural surgeon. Again, maybe you haven't done something in a while, but you have to have that done. So there are a lot of videos online. I'll catch myself just kind of brushing up. Maybe it's been a couple months since I've done something that I want to watch a quick video of, just to kind of get my confidence up before I go in there.
So I'm gonna turn now to Celeste. So Celeste was the chair of this medical student committee a while back, and then since the pandemic, Steve's been doing it. Celeste, as a medical student and as a strong medical student advocate and someone who's knowledgeable in this, what can a medical student do now to say they come from a rural place and they'd like to go back to it? How can they best prepare themselves for a career as a rural surgeon?
Well, thanks, PJ. I think that it's a great question. And one of the opportunities that I had in medical school was we were able to go and do a rural rotation as a medical student. And I actually did that with a family practice doctor who actually delivered babies and did basic surgical procedures. And it really gave me an understanding of what the resources were, what the practice was like. If you're thinking about surgery and you definitely know you want to do surgery, then during your residency, if you have an opportunity to do a rotation with a rural surgeon, I think certainly you can get an idea what that is like. If you are coming at this from a small town and think you may want to go back and practice there, then engaging with the surgeons and the physicians that are in practice there, now, and begin to talk to them, express your interest, find out what their needs are, find out what skills you need to make sure that you learn, and make sure you understand what it's going to be like to do that. I think you need to be extremely flexible. You need to be good technically. You need to be able to make good, solid decisions. A lot of patients don't want to leave their community. And I think the hardest thing for me is when parents ask me to do something that I don't think we should do at our hospital. And I have to really work hard to explain to them why I think they need to go somewhere else. So I think understanding, what you want to do and start campaigning now. I know a lot of people that went back to small towns and did rural surgery. They knew they were going back before they ever started medical school, and had a pathway and a relationship and stayed in touch. And so if that's what you want to do, that's what I would encourage you. If you don't know, I encourage you to try real hard to expose yourself through a rotation.
All right. We're gonna we're coming close to the end here. I'm gonna ask for a I can't remember which one of the fellows went to Gunderson. Remind me here.
That was me.
That was you. Okay. So I'm going to give you 2 minutes, and I'm going to give everybody else 1 minute because we're running out of time. But I do want to make sure I hit everybody here just one more time. But maybe you could just talk about Gunderson has been well known for its rural surgery tract, which continues today. Can you talk a little bit about how that is? And now you're up in Rochester. What is a rural surgery tract, and then I'll give you a couple seconds or minutes to answer that, and then I'm going to ask each of our participants for 1 minute response to a uniform question.
So Gunderson started in the late 60s, early 70s, really with the intent to train broad spectrum general surgeons who could go out into any community and practice the full breadth of general surgery. And that's what led me to go there. I wouldn't say it's a rural tract. It's one of the very few facilities in the country that I guess pride themselves on training general surgeons. Currently, there are 14 programs in the country that do so, and about 10% of the 260 odd programs that have some sort of rural tract. So, 25 programs out of 260 some odd programs have any exposure. And we definitely know that exposure to the rural surgery is absolutely key. So this is a thing that I'm incredibly passionate about. I think we just need to expose general surgery residents to what it's like to be in the rural communities and how much value they provide to these communities. It's just broad spectrum. So I was trained in, there were some questions. I did C-sections and thoracoscopies and vascular surgery and pediatric surgery. And when I came out, I did the full breadth of general surgery. Now my practice has changed over the years, and I'm much more involved in education and advisory council type stuff. But it's just a broad spectrum general surgery that you could go out with your skills and serve many different communities in the country.
Thank you. So, all right. So this is going to be the uniform question for all of our panelists, and I'm going to try to keep you to one sentence or two so we don't run out of time and Kim doesn't get mad at me. We'll start with Dan, who will, here's the question. What 1 or 2 sentence piece of advice do you give to somebody who is considering a career in surgery?
In rural surgery, you mean, or just surgery in general?
Surgery in general and or rural, your call.
All right. For rural surgery, if you're considering a career in that, go somewhere for a residency where you can get a real good broad training in general surgery. Like our colleague was describing at Gunderson. It doesn't have to be a place necessarily with a rural tract if you don't have that option. But get somewhere where you get some exposure to gynecology and ENT and urology and a broad variety of stuff. And then when you're there, put yourself in those positions, like as the chief, especially, go where you want and do the kind of cases you think you're going to be doing where you end up. I think that the more skills you come to the table with, the better you're going to be able to serve where you end up.
Thank you. All right, Brian, we'll go back to you. One or two sentences, best piece of advice for somebody interested in a career in surgery.
Yeah, work hard, get as much experience as you possibly can. And I echo what Daniel said. I think just participate in you never know what that might help a patient.
All righty. Brian, same question. One or two sentences of advice.
That was just Brian right there.
Oh, you were Brian. I'm sorry. How do you like that? Do you like that? I'm sorry. You got me all flustered with the whole being at Rochester with my old boss, Mike Rotundo. Russ.
Yes, sir. This is going back to one of the original questions we heard earlier too about work-life balance. I mean, I think it's possible. Anything's possible with everybody, no matter what field you guys go in surgery. And I think it's able to have a life. So I'm just going to give you one little tidbit that I heard. This actually started when I was going to college, and I've got my two boys coming in tonight who are finishing up their finals in college. But so life has three things, and you can divide it however, but when your work would be work, family, and social life. So you can pick any two of those three things and be good at them. You can't be good at all three. So if you want to have a life, or you want to have a family and you want to do good work, that is possible.
Awesome.
But you're just not going to be having a lot of partying on the side.
All right. Scott, one sentence piece of advice for the gang.
I would say choose a residency that provides broad spectrum training. Look at the case logs and understand what their strengths are, and then be a sponge. Learn everything that you possibly can from anybody.
All right. Thank you. And lastly, my good friend, Celeste, one sentence piece of advice.
I think make sure surgery is your tribe. Make sure it makes you happy. If those two things are true, you'll be happy and good at it, and you'll figure out how to make everything else work.